Hi, this is Dr. John Mehalik, Fort Myers, Florida, demonstrating the all-inside concept suture passing technique for rotator cuff repair. We have a moderate size rotator cuff tear here, which is U-shaped in nature, that we've begun our repair on. It's a delaminated tear that the greater tuberosity preparation has been completed on. And we begin at the most posterior aspect of the tear by placing an antegrade suture passer in through the most posterior leaf of the rotator cuff and coming in with that antegrade passer and taking the rotator cuff stitch, which is in the anchor closest to the cuff. You'll see that we'll then thread this suture out through the most posterior aspect of the cuff, removing the soft tissue that seems to be in our way there. The next thing we'll do is use the antegrade suture passer again, and passing a second suture adjacent to the first one a little bit more anteriorly in the cuff. And as we come through with this antegrade passer, what we'll do is grab the central suture within the anchor, which will be the blue one, which is closest to the rotator cuff, and thread that through the remaining rotator cuff tendon. Then we'll switch over next to the all-inside concept suture passing technique. You're seeing this video in real time for a reason, and that's to try and demonstrate the efficiency with which sutures can be passed when we use this concept device. So we're visualizing from the 50-yard line portal. There you can see the prepared greater tuberosity and our triple loaded Super Evo anchor in place. We're placing an accessory anterolateral portal here, and you'll see our concept device coming in. We'll then take the lower jaw of the concept suture passer and manipulate the sutures within the anchor to identify the stitch which is closest to the cuff and the one we wish to pass through the tendon. What we do then is place it through the slot in the lower jaw of the concept passer, advance the passer to the desired position for piercing the tissue, and then fire the passer in the standard fashion, allowing for a full thickness bite of this delaminated rotator cuff tissue. You'll see the suture coming up and through and into the jaw to be passed through the same cannula out through our accessory anterolateral cannula. What we'll do then is take all three of these sutures out through the most posterior cannula and allow them to rest until later tying. This will allow them to be out of the way for additional suture passing. You see our three non-post strands there being removed, and now the adjacent passed strand being removed. You'll see now a second Super Evo anchor being entered down deep inside the bone through a separate pilot hole, through a separate pierce in the skin. And once this second 3VO is down inside the bone, we'll then take the concept suture passer and, in a similar technique, pass each of these three sutures through the torn edge of the rotator cuff. I prefer to use titanium anchors in situations like this. Good quality bone. I'm able to see it on x-ray in the post-surgical period. It doesn't cause any reaction within the bone, and in addition, it's buried down below the bone, allowing for a good tendon-bone interface without interference from synthetic materials. So you'll see now, beginning along the most posterior aspect, we'll pass the white stitch first, and we'll come in again with our concept suture passer and manipulate the stitches within the anchor using the lower jaw of the suture passer as a manipulating tool. You'll see we'll place the white stitch here within the slotted portion of the lower jaw, advance it over the delaminated rotator cuff, and we can grab a very large bite up to about 18 millimeters of tissue here using the device and passing it down using the concept needle. And with each of these passes as well, our options are to either pull the sutures out into the anterolateral cannula where we're working, or the alternative solution would be to take each one of those sutures as we pass them and allow them to rest in the posterior cannula, which is my preference in this case, to keep the sutures out of the way and allow for better organization. The next pass now will be the central suture. And again, what you see here with this style of passing is we do it all inside, so there's no risk of tangling sutures as a consequence of suture management issues, whether we grab the sutures on the wrong side or interpose some soft tissue in between. This is a technique that is independent of suture management to some degree because it's managed all inside the joint. And this is one of the major advantages. You get to avoid all the pitfalls that come along with suture management issues, and then you also get to take advantage of the efficiency of a single shot style of device that both grasps tissue as well as pierces the tissue at the same time through a small nitinol needle puncture hole. So as you can see, again, we're watching in real time here. We're about 5 minutes into the video, and we've passed a total of 5 of these stitches already and are ready for tying already. And we're just about to pass our 6th stitch right now. So again, you'll see this 6th stitch come through. The one additional advantage of this device is that we can pass blindly. So you'll see here as we rotate the grasper over anteriorly, there's some soft tissue that somewhat obstructs our view as to where the needle would come out. But the good news is that this device, once passed, the window opens, capturing the suture in a blind fashion and allowing you to withdraw the suture on the opposite side of the tendon. So we manipulate the tissue, we pass the stitch, it goes through the window grasps the superior surface of the stitch and allows full passage through without us having to directly visualize. This has other advantages in situations where it's not just rotator cuff repair, but maybe for biceps tenodesis, for subscapularis repair, and so forth. Now what you'll see is we've passed our sutures posteriorly to anteriorly, and now what we're going to do is take our sutures one by one from anteriorly to posteriorly, and we'll tie each one of them down. We'll use a sliding locking knot in each one of these cases, sliding it down into the joint to create good apposition of rotator cuff tissue down to good bleeding bone bed. And then once we have each of those sutures passed, we'll cut each of the suture tails, leaving just a 3 millimeter tail inside with a good strong hi-fi suture holding each of these in place with 6 good simple sutures by the end of this arrangement. So you'll see here the most anterior stitch now has been tied. We'll tie our half hitches in an alternating fashion, one by one, an underhand, then an overhand, then an underhand. And here you see the finished product, a very robust repair of the rotator cuff from anterior to posterior with good apposition of rotator cuff tissue down to good bleeding bone bed. Very good healthy bites of rotator cuff tissue to create a good bridge of tendon so as not to pull out hi-fi suture through the tendon, and a very secure repair. Thanks for your attention.